welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Mara Schenker and Jesse Seilern. Mara is an orthopedic surgeon. Jesse is a postgraduate research fellow, and together they co-wrote the Kevin MD article, America's Prescription Epidemic, Breaking an Ancient Promise. Mara and Jesse, welcome to the show.
Thank you.
Thank you very much for having us.
So I'm going to ask each of you to share your stories and journey to where you are today. Jesse, why did you go first?
Absolutely. So thank you for having us. First of all, I'm a postgraduate research assistant, and I am here at Greater Memorial Hospital on one of many journeys, I guess, for young aspiring surgeons. My story starts in Austria. This is where I was born, in Vienna, actually the capital city of Austria. And so I spent a lot of my childhood and youth education in Europe, including Germany and the UK. However, my undergraduate degree I earned in the USA and with a sports scholarship. So my previous career was in athletics, after which I then started to pursue a medical scholarship to become an orthopedic surgeon, which led me to be an apprentice of some sort and also a research fellow of Dr. Mara Schenker here in the US. And so this is how I ended up on this research team about roughly a year ago. And we've been doing great things in the research world ever since.
So Jesse is an aspiring orthopedic surgeon and traveling down that path. What are some of the biggest challenges that you faced thus far?
The challenges basically are just staying diligent. I think keeping the goal in mind that you want to reach. As we all know, the road is pretty long. For me, it's been especially long since in Europe, most medical schools are 6-year programs. And knowing that going into medical school definitely helped. That I will be in school for 6 years and then practice and train orthopedics for 5 more years before becoming somewhat independent. But that's the road that is the most fun part to me in pursuing something that takes time, takes practice, and takes diligence. So to circumvent your question, is nothing really that's hard. It's just more of a question of whether you're willing to do it or not.
And Mara, can you please share your story and journey to where you are today?
So I grew up in Pittsburgh, Pennsylvania, and I also had a previous career in athletics. I used to do competitive martial arts, taekwondo. Did that for 20 years, went to college at the University of Pittsburgh, medical school at the University of Chicago. I did my year of research out in Vail, Colorado in orthopedics, which is very similar to Jesse and a lot of the people who I've mentored that I had a very similar research experience to what he has. And then I did my residency in orthopedic surgery at the University of Pennsylvania. Did my fellowship at Harborview Medical Center in orthopedic trauma in Seattle, Washington. And I've been at Grady now since 2015. I recently took over as the chief of orthopedics for Grady and the director of orthopedic trauma. And I decided I liked school so much that I'm starting my MBA in January of this year at Kellogg.
And for those medical students who are interested in perhaps a career in orthopedics, what's your biggest piece of advice?
I get asked this question a lot, and I always bring it back to my taekwondo story. When I was in college, I was doing taekwondo competitively, and I can remember somebody who was in a career advisory position saying, "Why are you wasting your time with this? You should be doing X, Y, and Z." And at the time, that was what I was passionate about, what I absolutely loved. And I remember thinking, well, that's not great advice because this is what I enjoy. And then the day that I won the world championships, no one's ever asked me that question ever since. I was asked to walk a predictable line, and I said, this is not where my passion actually is. And then when I demonstrated that I had what it took to be very successful in that world, then all of a sudden, all of those doubts and fears went away. And so my advice to students is do what you're passionate about, do what you love, and do what you love well, and the rest will just fall into place.
And you also mentioned a story that you're pursuing an MBA degree. Why is that?
Yes, I also get asked that question a lot. My interest right now is in the intersection between health informatics, so the medical record and data, and efficiency and cost containment in trauma care in particular. And I think there is a huge gap. I think a lot of other industries have figured out how to navigate the data better than healthcare has. And so my interest is in potentially partnering with industry to bring in some of the other technologies that have been developed for other industries into healthcare, specifically in the informatics side of things.
Wonderful. So let's transition into the article that both of you are among the co-authors of. It's titled America's Prescription Epidemic, Breaking an Ancient Promise. Jesse, for those who didn't get a chance to read that article, can you just walk my audience through it and share the story of why you guys decided to co-write it?
So I guess I'll start with the inception of this article and when this idea was created to actually put it to paper. It was during one of our research meetings that we have weekly with this academic community partnership between the Christopher Wolf Crusade, which is an NGO that's committed to patient education and behavioral approach to pain management, especially in light of the opioid epidemic and those staggering. Dr. Schenker's established a great partnership with them to do some research projects in seeing how this implementation of this strategy actually works in the orthopedic trauma setting. So in one of these meetings, we're discussing the situation of a patient coming out of the CVS pharmacy with a full bottle of prescriptions, and the full bottle of prescription medication is opioid medication. And they're actually well intended by the physician and whoever was involved in the clinical care of this patient. However, at some point, there was just a loop, just maybe, I guess, just a hole in the treatment or in the timeline where the patient did not receive education on these opioids. And most of us know someone, or even know someone who has had problems with addiction in the past, and walking with a full bottle of these pills to the car or out of the pharmacy, unknowingly having a really high potential of side effects or that risk that's associated with these medications was a little bit staggering, and also can give you some goosebumps thinking about it. If it's your wife, if it's a person that's dear to you, and all the things that could happen if the patient's not educated on these medications. So that was basically the inception of the article, and this idea perpetuated to where everybody knows one, so to say, and in this case, it was a dear family member of mine who received one of these medications, and just that conflict that a physician has by actually treating the patient and giving the patient adequate pain control, but on the other hand, knowing the effect that it can have if something goes wrong. Numerous scenarios, the patient itself forgets how many to take and takes one too many, or maybe two too many, or even the patient leaves a prescription medication unattended in a children's room or somewhere else, or somebody who has access to the medication stash can actually reap those, negative side effects that this full prescription bottle could bring if the patient not educated properly on it. So to bring this conflict to light, this article was created to basically illuminate that we physicians swear an oath to protect the patient, but also, not overtreat a certain injury or overtreat a certain condition to where it actually could harm the patient. And this is the fine line that we're trying to find, or that at that time we were trying to find on how to best navigate that situation if it ever arises. And I think we have a couple of answers to this. And one of them is based in our many research avenues with this community academic partnership with the Christopher Wolf Crusade here, which we can talk about in a little bit.
Jesse, and when you say that patients are not adequately educated about the dangers of opioid medications post-op, what exactly do you mean by that?
So that is, I guess, that could be a generalization that I was stating. However, it is a generalization that I'm willing to make just to raise awareness to this point, where you will see some patients who, for one profile, are prescription abiding patients who take the prescription as prescribed or take the medication as prescribed, and thinking that that is a protective effect of, risk of addiction or anything else of that. And then you have patients who unknowingly take medication just because of the fact that they have a lot of pain and do not know of the risk of addiction. So we find that, especially in an orthopedic trauma setting, patients who get hit by pain and are opioid naive, in a better word, a better sense of words, who never had opioid medications before, do not necessarily know what the medication is or how to deal with the medication, or if there are even other ways of treating their pain. So for them, this opioid education is something new, And as we all know, it's a stressful time if you come into the orthopedic trauma population with a severe injury. You most likely will remember only half of what your healthcare team has discussed with you. And it may be that at one point, medication abidance was discussed with you and you forget, or it may even be that this completely fell through the loops and you did not discuss with your physician or with your discharging nurse the schedule and the risk factors and the side effects that you should be aware of when taking these narcotics after you get discharged from the hospital.
Mara, can you take us through a sample post-op course, especially when it comes to post-operative pain? What normally happens after an orthopedic procedure in terms of managing post-op pain, and take us maybe through a journey from the post-op course through discharge of in the hospital?
Sure. So what I do is a little bit different than a lot of orthopedic surgery in that our surgery is unplanned. And so the patients are coming to us with a significantly painful injury, but we haven't had an opportunity to discuss with them pain control afterwards. And so that is challenge number one. We have done everything we can prior to this partnership with Christopher Wolf Crusade to standardize our prescribing practices. So making sure that, you have X, Y, and Z, that here's your taper that you're going to be on for a period of time after your trauma, with the goal of getting everybody off of opioids within 6 weeks. And one of the challenges that we came up to was that there's not a lot of great alternatives. And so I was trained, we were all trained that, patient has a score, you're asked your pain score 0 to 10, somebody has a pain score of 5, and the answer to that pain score of 5 is a medication. And so that's a problem. And one of the solutions that we've come up with is we actually have a new member of the healthcare team. It's called a life care specialist that is there to both educate on the opioid side, but then also to provide patients with alternative like behavior-based strategies for pain management after trauma. And so that's now become a part of our course in the postoperative process. And so that alone has made a huge difference because it does give them an alternative. They feel like people are paying attention. They have a human being who's there to be able to give them personalized, like, here is an opioid, here are the risks of opioids. We understand that you have pain, and there are other options for managing your pain outside of a pill. So that has worked extremely well for us. We're still in the research phase there. We have 4 life care specialists at Grady right now in our orthopedic trauma department, with the hopes and plans to expand to more. I think it's made a huge difference. And it when you look at how we've approached the opioid epidemic in the past, it's all been very prescriber focused. Mm-hmm. So reducing the number of pills that I prescribe, this is very patient centric. So prevention, but also acknowledging that pain is very real and that we have other options outside of the pills.
Mara, when you talk about behavioral approaches to pain management, what exactly do you mean by that?
Sure. So they teach them mindfulness strategies. We use the community resiliency model, which is something that's been well described in other industries, but hasn't necessarily been used in the orthopedic trauma population for pain. And we use deep breathing, reflexive listening, and motivational interviewing and things along those lines. But we also very much get into the patient's background. So we ask a lot of social determinants of health questions and prior substance use questions, and really acknowledge the patient's where they're coming from.
And what exactly would that look like in terms of follow-up for this behavioral approach to pain management? Would they be in contact with some type of clinician or coach several times a week? So what would that look like?
Sure. So right now we're still in the process of trying to figure out what that is and who the best patient is to work with a life care specialist. They see our patients whenever they're in the inpatient setting. And right now we're following them up to 3 months post-operatively. So ideally to get them to the point where they're no longer needing medications. And we'll see. Some patients may need shorter term follow-up. Like if I were a patient, I might just need somebody to come in and check in with me and say, hey, here's some alternative strategies for pain medication, but you don't necessarily need the opioid education side of things. But some people need the full opioid education and also need the continuous check-in. And so that's one of the perks of having a real human in this process, is they're able to, and they're trained to recognize how often somebody needs to be checked in with. And so we're about halfway through our randomized controlled trial that we've been doing. We have a pilot series of about 120. And our current study, we're about halfway through, or a little over halfway through. We should have findings by hopefully next summer to help us define what this looks like.
And Jesse, have you run into any obstacles or roadblocks when it comes to implementing your program?
Not necessarily. The only point I would I would want to make is that with orthopedic trauma, we are basically exposed to patients who are at a higher risk for any type of substance abuse, really. So I think we're definitely hitting the nail on the head by implementing these strategies in this population. As we all know, it's really feasible to do it in the elective surgery population. We have all the time we want and all the time we need to educate somebody before or even the surgery, but in an orthopedic trauma patient, we don't. And on top of that, we have the high risk of the orthopedic trauma patient already having propensity for these associated factors, you know, with addiction and substance abuse. So I think the challenge of getting to that patient is really, just like Dr. Schenker pointed out, knowing that patient, knowing the profile of that patient in order to tailor some of these behavioral strategies.
We're talking to Mara Schenker and Jesse Seilern. Mara is an orthopedic surgeon. Jesse is a postgraduate research fellow, and together they are among the co-authors of the Kevin MD article, America's Prescription Epidemic, Breaking an Ancient Promise. Now I'm going to ask each of you for your take-home messages to the Kevin MD audience. Jesse, I'm going to have you go first.
My take-home message is that given the current pandemic, we shall still not forget that the opioid epidemic is, still not a problem of yesterday. It's quite recent in everyday's lives. And, even though it's not making the same headlines as COVID-19 at the moment, it's still a serious issue in the United States. And it's not really close to being resolved. So I think focus on the research side and also on the clinician side should still be put on this topic. And what we've learned so far is that patient-specific and patient-centric education is definitely a feasible way to pursue some of these problems that the opioid epidemic has brought.
And Mara, what's your take-home messages that you want to leave with the Kevin MD audience?
Sure. My take-home message is that we need to really think about the patient when we're looking at strategies for pain management, reducing the risk of the opioid epidemic. Prior focuses have mostly been on the prescriber side, and I think we have a lot of work to do on the patient side.
Mara and Jesse, thank you so much for sharing your time and insights, and thanks again for being on the show.
Thank you.